Hi there. Welcome back. Today we're diving into the respiratory system. Now, the respiratory system is arguably one of the most cinematic body systems. Like, the whole thing is just one long dramatic journey of how air gets in to the body, how gas exchange happens, and how you literally make sound with just cartilage and muscle. It's a lot of genuinely cool stuff. So let's get right into it. My name is Tarun Balaji, and here are some of our goals for today. We want to understand the general functions of the respiratory system, and spoiler alert, it does way more than just breathe. We're going to differentiate the divisions of the respiratory tract and look at some regions in specific. We'll also get a chance to dig into some lung anatomy and look at gas exchange. So what does the respiratory system actually do? Let's run through it. So this is what most people think of. The primary function of the respiratory system is ventilation. Ventilation is the physical process of moving air in and out. Inspiration pulls air in using negative pressure, meaning the thoracic cavity expands, pressure is going to drop below atmospheric, and air rushes into your lungs. Expiration pushes air back out. When you're at rest, this process, expiration, is actually passive. It's driven almost entirely by elastic recoil. We'll come back to this later. Number 2, gas exchange. Getting oxygen into the blood and getting carbon dioxide out of the blood is super important. This happens at the level of the alveoli, and it is gorgeous when you think about the scale at which it's happening. Third function, air conduction. We want to make sure that the air we're breathing is appropriately conditioned before it reaches the level of the lung tissue. Now, this one surprises people. How does the respiratory system regulate blood pH? Well, carbon dioxide dissolves in blood as an acid, carbonic acid. So how fast you breathe directly affects blood pH. If you blow off too much carbon dioxide, you're going to enter alkalosis. If you retain too much carbon dioxide, your blood's going to get a little acidic, leading to acidosis. Wild, right? A major function of the larynx is sound production. Your larynx, or your voice box, is a biological instrument. We'll absolutely be getting into this a little later. And olfaction. Smell is a respiratory function. Air is going to carry molecules of odor to receptors in the upper nasal cavity. Olfaction is carried by cranial nerve 1, your olfactory nerve. And last but not least, defense. The respiratory tract is heavily invested in keeping gunk and garbage out of your lungs. We've got mucus, cilia, immune cells, the whole security apparatus. Alright, let's split this thing up. The respiratory tract is divided into an upper and a lower half. The upper half, so we're talking the nose, the nasal cavity, paranasal sinuses, your pharynx and larynx, is all about conditioning the air. We're gonna warm it, humidify it, and filter it before the air goes anywhere important. The lower respiratory tract, on the other hand, we're thinking trachea, the bronchial tree, which is the bronchi branching out into smaller bronchioles. The lungs and the alveoli are going to handle conduction and gas exchange, the actual brunt of the gas functions. Here's a slightly different way to think about the same thing. Zones instead of divisions, and this is really important for understanding histology. The conduction zone is going to run from your nose all the way down to your terminal bronchioles. The job of your conduction zone is to prepare and move air. So remember, as I was talking earlier, we're warming it, we're humidifying it, we're cleaning it. We've also got shared passages along your respiratory tract. What do I mean by shared passages? Think about your oropharynx and your laryngopharynx. These are shared spaces between food, water, and air. And this is why you're gonna have stratified squamous epithelium. This is thick and tough, at least compared to your respiratory epithelium. And it makes sense because you're gonna want to withstand abrasion from both food and air. The respiratory zone, on the other hand, is gonna start at the level of your respiratory bronchioles, and it goes all the way up to the alveoli. This is where gas exchange is going to start to happen with blood. Now, passages that carry air only are lined with mucous membranes of some sort. This includes the respiratory epithelium. A lot of the respiratory tract is lined with this special tissue that we're calling the respiratory epithelium, and it's worth knowing the actual legal name. It's pseudostratified ciliated columnar epithelium. Oh my. Now, if you're intimidated by the name, don't be. Let's break it down. Pseudostratified because it looks multi-layered, but every cell's actually gonna touch the basement membrane. It's essentially LARPing as a stratified tissue, even though it's not. We've got these tiny little hair-like projections on the surface that beat in coordinated waves. They're moving unidirectionally towards the throat, away from the lungs. Now, why might this be significant? We're gonna want to move mucus and all the gunk that's trapped in your mucus upward towards the throat. And columnar, because these cells are taller than they are wide, kind of like a column. Scattered amidst the tissue is goblet cells. Your goblet cells are going to secrete mucin, which when combined with water is going to become mucus. The mucus is going to trap dust, pathogens, and other small particles. Then your cilia is going to sweep it up and move it towards the pharynx, and it's ultimately going to get swallowed. Yeah, you heard me right. You swallow your own lung mucus almost constantly. You're so welcome for that fun fact. Underneath the epithelium, you've got a thick basement membrane and the lamina propria. This is going to contain seromucous glands, which is going to make additional secretions. The respiratory tract, despite the name, is not found all throughout the respiratory tract. You've got a few exceptions. For instance, the oropharynx and the laryngopharynx are a super common one because these are shared passageways between food, water, and air. You need something tough, not something that's ciliated and delicate, which is why you're going to have stratified squamous epithelium. Your respiratory bronchioles are the transitional zone. This is where you're switching to cuboidal epithelium. The deeper you go, the simpler the lining gets. Because when you think about it by this point, you've already filtered all of your air upstream, and you're going to want to start transitioning to thinner walls for gas exchange to start happening. And your last exception, last but not least, the alveoli. Your alveoli is going to be lined by simple squamous epithelium, the thinnest possible lining, because it's just one layer of cells. If you didn't already know, gases are super lazy. If you want gas to diffuse across a barrier, you're gonna want it as thin as you possibly can afford to have it. Which is why this works perfectly for gas exchange. Alrighty, now let's follow the passage of air through the respiratory tract. We're gonna start at the nasal cavity and the nose. Let's move from top to bottom now. The external nose is built from a bony framework. The frontal bone's located superiorly. You've got two nasal bones in the middle and the maxilla at the base. You've also got a cartilaginous framework that forms the shape of your actual nose tip. The cartilage framework, there's a bunch of different cartilages. We'll want to think about the lateral nasal cartilage and the alar cartilages as forming the outer part, and the septal cartilage, as forming the midline partition. The openings of your nostrils are called external nares. You can also call these external nares if you want to be fancy, but I'm just going to call them external nares. Once you're past the external nares, you're entering the nasal vestibule. The nasal vestibule contains vibrissae, the legal name of your nose hairs. That's your first line of defense right there. Your vibrissae and your mucus are going to create kind of like a sieve or a mesh to make sure large particles don't pass through. Your nasal cavity, once you're past the nasal vestibule, is kind of like a little house. It's this little house that has a roof and a floor. The roof is formed by your ethmoid plate. In specific, it's formed by the cribriform plate of the ethmoid bone. Your ethmoid bone, the cribriform plate, is going to have tiny little holes, tiny little foramina for nerve fibers. These nerve fibers are from cranial nerve 1. Do we remember what they are? They're olfactory nerves. They're going to receive special sensory information, aka olfaction or the sense of smell. The floor of your nasal cavity is the hard palate. You can actually feel the hard palate with your tongue on the roof of your mouth. So kind of makes sense that the roof of your mouth also forms the floor of your nasal cavity. Now, there's a wall in the middle of this house, the nasal cavity, that splits it into a left and a right. This midline wall is the nasal septum, and it's made up of 3 parts, 2 bones and 1 cartilage. Superiorly, we're gonna look at the perpendicular plane of your ethmoid bone, and inferiorly, we've got the vomer. Now, in between these bones, you've got an anterior projection of septal cartilage. All of these are covered by mucous membranes and form the nasal septum. Now, you can have a condition called deviated septa, and this arises in different degrees of severity. Deviated septa are actually extremely common, and it's why people tend to breathe better through one nostril than another. Now, just like your external nares by the entry, the exit has a specific name. We're calling these the internal nares. Now, some textbooks might call this the choana. I'm just going to call it the internal nares. This is essentially a portal into the pharynx. Air is going to flow from the external nares, aka the nostrils, into the nasal vestibule, into your nasal cavity, and it's going to exit from the nasal cavity via the internal nares into your pharynx, the nasopharynx to be specific. Now, on the lateral walls on each side of the nasal cavity, you're going to find bony shelves. These are called nasal conchae. There's 3 of them. We've got a superior, middle, and an inferior nasal concha. Now, the superior and middle are projections off of the ethmoid bone. The inferior nasal concha is its own bone. There's little spaces between each concha called meatuses. Again, these are named after the concha. We've got the superior meatus below the superior concha, the middle meatus, and the inferior meatus. Now, here's why they matter. The conchae and the meatuses are slowing down incoming air. Instead of letting air shoot straight through, air is going to swirl around these turbine-like structures and give it time to warm up. It's going to pick up some moisture and drop off any gunk or particles that it might be carrying. It's kind of like a mini climate control center. In the middle meatus, you're going to notice something called the ethmoid bulla. The ethmoid bulla is a bulge formed by ethmoid air cells. We'll look at these in a little bit. Now here's a nice diagram that shows a few structures called the paranasal sinuses. What are the paranasal sinuses? These are essentially spaces of air located within your facial bones. Paranasal because they're located adjacent to your nasal bones. Now, three of these are paired. You've got frontal, sphenoid, and maxillary sinuses, and you've also got ethmoid air cells. Now, instead of having a single large sinus in the ethmoid bone, you've got a bunch of tiny air spaces, air pockets, called ethmoid air cells, and these, as you might recall, drain into the ethmoid bulla. Now, why do we have these large sinuses? Your nasal sinuses are going to contain mucous membranes that produce mucus to keep your nasal cavity all moist. We don't want it drying up because there's so much neurovasculature on the internal walls of your nasal cavity. Letting it dry out would not be very good. Your paranasal sinuses also help lighten the skull. Imagine having thick, solid, rock-like bone here. That would make your head impractically heavy. It also helps you resonate your voice. This is why if you've had a congestion or a cold, you're gonna notice some significant changes to the timbre and tone of your voice. Your paranasal sinuses are also gonna act as a crumple zone for facial trauma. They're gonna help absorb impact of a blow to the face before it reaches any critical structures. Now, what does the nasal cavity in general do? The upper third of the nasal cavity is lined with this olfactory epithelium, which contains chemoreceptors for olfaction or the sense of smell. Again, cranial nerve 1, the fibers of your olfactory nerve are going to be located with your olfactory epithelium. The lower 2/3 are covered in respiratory epithelium. Now, since the nasal cavity is highly vascular, it's going to warm incoming air rapidly. The mucus is going to moisten the air and trap particles, and the cilia is going to beat mucus towards the pharynx and hopefully help you swallow it. Once you swallow mucus, it's going to end up in your stomach in a highly acidic environment, which hopefully kills off any pathogens that might be remaining in there. When you think about the cilia and the mucus, they're constantly clearing debris. Your mucus is going to trap particles, cilia is moving it up towards the pharynx. It's kind of like this escalator of cleaning, if you want to think about it that way. Now, nose jobs. Let's talk about nose jobs. I bet that this wasn't a sentence you were expecting on hearing today, but nose jobs or rhinoplasty can be done for cosmetic reasons or more functional reasons, like correcting a deviated septum or repairing a fracture. This process can use local and general anesthetic, and the surgical procedure is gonna essentially make sure that nasal cartilage is reshaped. How are we accessing your nasal cartilages? We're typically accessing these through your external nares. Remember the outer nostrils? The external nares are gonna lead into the nasal vestibule. For rhinoplasties that involve bone work, your nasal bones are carefully fractured under a controlled environment and repositioned. Afterwards, you're gonna pack them up and a splint's gonna hold everything until healing takes place. Now, this probably helps you appreciate the anatomy a little more. Next up, we're at the pharynx. The pharynx is a muscular tube that runs from the internal nares all the way down to the cricoid cartilage. It's made from skeletal muscle lined with a mucous membrane. Your pharynx has 3 major jobs. It's a passageway for food and air. Remember, this is mostly a shared corridor. It's a resonating chamber for speech, and it also helps with immune defense. How so? It houses tonsils, some lymphatic tissue, and it sits by the entryway into the body. It's also divided into three distinct regions: the nasopharynx, the oropharynx, and the laryngopharynx. Let's take it one by one. Your nasopharynx is the most superior portion. It runs all the way from your internal ears down to the soft palate, by the little punchy bag thing at the back of your throat, the uvula. This region carries air only. Food, hopefully, doesn't get here. It's lined with respiratory epithelium. Remember the pseudostratified ciliated columnar epithelium we were talking about? Yeah. Since it's air only, we kind of want to retain the mucus and cilia defense system. Your nasopharynx is also going to contain the openings to the pharyngotympanic tubes, i.e., your eustachian tubes. You might see textbooks calling it the eustachian tubes, but in this class, we're going to call these the pharyngotympanic tubes because they connect the pharynx to the tympanic tubes, or the middle ear. This is why you can pop your ears by swallowing or yawning. Your pharynx is connected to both of your middle ears. Your pharyngeal tonsil also sits in the roof of your nasopharynx. These are clinically referred to as the adenoids, and it's an aggregate of lymphatic tissue that watches for pathogens coming in from the nasal cavity. Now, the uvula, remember the punchy bag looking thing at the back of your soft palate? It forms a loose seal between the nasopharynx and the oropharynx. This is important because you want food sliding down into the esophagus and not up towards the nasal cavity. Speaking of food, the oropharynx is going to run from the uvula down to about the level of the hyoid bone. Over here, you're going to see your palatine tonsils. Now, palatine tonsils are the most commonly affected tonsils when it comes to tonsillitis. At the base of your tongues, you've got another set of tonsils, the lingual tonsil. Together with the pharyngeal tonsil, the lingual and the palatine tonsils form the structure called Waldeyer's ring. It's a circular arrangement of lymphatic tissue around the entry points from the nasal and oral cavities. Most of the epiglottis is also found in the oropharynx. The epiglottis is a little flap that covers the larynx when you're swallowing food and water. The little flappy thing. Your laryngopharynx is next, and it runs from the hyoid bone to the cricoid cartilage. Now, your oropharynx and your laryngopharynx are lined with stratified squamous epithelium since they carry both food and air. This is where paths diverge. Your laryngopharynx is going to contain an opening to the larynx in the anterior part, and if you don't take the opening, it's going to continue into the esophagus inferiorly. When you swallow, the epiglottis folds over that laryngeal inlet. This is going to direct food or water into the esophagus and not your lungs. If this fails, that's essentially choking. Alrighty, let's talk about your voice box. Your larynx, aka the voice box, is going to sit anterior to the esophagus or the esophagus. It's approximately level C4, C6, spinal C4, C6, and you can actually feel part of this apparatus. When you talk about your Adam's apple, your laryngeal prominence, that's part of the larynx. Structurally though, it's a cartilage and connective tissue tube. Here's the full hyoid cartilage complex from 3 different angles. Get comfortable with this visual because you're gonna want to remember this. The first part of your hyoid cartilage complex is the hyoid bone. While technically it's not a cartilage, it's a bone, and it's famous for being the only bone in the body that doesn't articulate with another bone. It kind of just floats up there, suspended by muscles and ligaments. How fun. The hyoid bone and the hyoid cartilage complex in general are gonna protect the larynx, provide insertion for a bunch of different muscles, including your intrinsic laryngeal muscles, and an insertion site for your vocal cords. Let's talk about the largest cartilaginous constituent of your hyoid cartilage complex, the thyroid cartilage. The thyroid is the largest laryngeal cartilage. It is shaped like a shield. Fun fact, thyroid literally comes from the Greek word thyros, meaning shield shape. It's this C-shaped structure when you're looking at a cross section. Or you could actually think of it as a broken ring. Most of its structure is held in the anterior and lateral parts. The lateral halves, like I mentioned, are gonna fuse anteriorly, forming this tiny bridge called the laryngeal prominence, aka the Adam's apple. It's also the origin for the vocal cords. Your vocal cords are gonna attach anteriorly to the inside of the thyroid cartilage. Now, your laryngeal prominence is more prominent in people who underwent testosterone-driven puberty. A lot of biomechanics, but testosterone promotes the angle of fusion to be more sharper, which makes the protrusion a lot more pronounced. The second cartilage that sits right below the thyroid is the cricoid cartilage. It's also a single cartilage, but unlike the thyroid that's open at the back, the cricoid is one complete ring. It's narrow anteriorly, but as we move backwards posteriorly, it's gonna expand. It expands as it wraps to cover the posterior larynx. Think of it like a signet ring, only the gem part is gonna face backwards. Now, for the paired cartilages, you've got the arytenoids. These are super important. There's two of them, and they're sitting on top of the posterior part of the cricoid. Each arytenoid has two important projections. We've got the vocal process and the muscular process. The vocal process is where the posterior end of your vocal cord inserts, and the muscular process provides sites of insertion for intrinsic laryngeal muscles that help with vocation and phonation, aka making sounds. There's also two more cartilages that we don't expect you to remember and recall for the exam, but they're called the corniculate and the cuneiform. They've got kind of ancillary functions, but that's kind of the reason it's called the hyoid cartilage complex. In total, you've got your thyroid cartilage, the cricoid, two arytenoids, two corniculates, and cuneiforms. Now, here's a fun little demonstration that you can do on yourself. I want you to take either your right or your left hand, take your middle finger and place it right above your laryngeal prominence. Kind of like so. Now, if your middle finger's on the laryngeal prominence sitting right above it, your pointer finger, your index finger is on the hyoid bone. Your ring finger is on the thyroid cartilage, and your pinky finger is sitting in the space between your cricoid and the trachea. Now, I hinted at this earlier, but let's actually talk about vocal cords and sound production. Wait, hold on a second. Why does it say vocal folds? A vocal fold is basically a vocal cord when it's covered by mucous membrane. Since they're delicate structures that need to be protected, you've got two sets of vocal folds. The set that's most anterior, so the one that you're going to access first, are called vestibular folds. Now, these are false vocal folds. These aren't the actual ones. They're sitting above the true ones, and they're primarily protective. They close pretty tightly during swallowing because Again, we don't want any food or water getting into your larynx, past your trachea into the lungs. We don't want that. Now, the true vocal folds are the actual sound producers. Each vocal fold contains vocal ligament, which is the elastic ligament that gives the fold the tension properties, and a skeletal muscle called vocalis. Now, here's how sound is made. When your intrinsic laryngeal muscles contract, it's going to move the arytenoid cartilages. When you're moving the arytenoid cartilages, it stretches the vocal cords. Think about this like tightening guitar strings. This is a deduction of your arytenoid cartilages. So when air is pushed past the taut ligaments, they're vibrating and producing sounds. If you increase tension, tense your ligaments, you're going to increase the pitch. If you're increasing air pressure, on the other hand, you're going to increase amplitude, the volume. Your oral cavity, pharynx, and sinuses are then going to act as resonators that shape the sounds into more recognizable words and speech. They're adducted or closed on the left and abducted, abducted for breathing. The gap between the vocal folds is called the rima glottis. When you're breathing quietly, the cords are abducted. We're gonna want to keep the rima glottis open. When you phonate, however, make sounds, your vocal cords are gonna rhythmically adduct. When you do a Valsalva maneuver, which is kind of like bearing down, lifting something heavy, both the false and the true vocal folds are going to clamp shut, and this is gonna build up intrathoracic pressure. Now, there's 3 functional categories of intrinsic laryngeal muscles. First up, we've got the abductors. Your abductors are going to open up the rima glottis. Think AB, abduction, taking it away. Oh no, they're abducting. They're abducting each of the vocal ligaments, the babies. Oh. The main abductor is the posterior cricoarytenoid. Now, damage to the actual muscle or the nerve that supplies this muscle is a big deal. Since this is the major abductor, damage to this muscle can leave the folds stuck in a closed position. Your adductors, on the other hand, are going to close the rima glottis. They're going to add it together. This is performed by your arytenoid muscles. Your arytenoid muscles are going to pull the cartilages together and bring the folds towards the midline. Your tensors and adjusters are going to control pitch. For instance, the cricothyroid muscle. Your cricothyroid muscle is going to tilt the thyroid cartilage forward relative to the cricoid, like a little dip. If your thyroid moves anteriorly, moving forward, it's gonna stretch the vocal ligaments, increase tension, and raise pitch. Now, if you're thinking falsetto, kind of like, that's extreme cricothyroid activation. All of these muscles are innervated by a branch of cranial nerve 10, aka the vagus. Down we go into the lower respiratory tract. Now that we're past the cricoid cartilage, we're now in the trachea. The trachea extends inferiorly from the larynx and eventually splits into 2 main bronchi at the carina. Structurally, we're thinking 4 layers. The innermost layer is the mucosa. This is the same respiratory epithelium that we've been talking about all this while. So say it with me: pseudostratified, ciliated, columnar epithelia. The second layer, right underneath the mucosa, we've got the submucosa, sub underneath the mucosa. You're going to find loose connective tissue here, along with a bunch of seromucous glands. The trachea gets its characteristic ribbed appearance from hyaline cartilage. You've got about 16 to 20 C-shaped rings. Now, remember, just like the thyroid, these are unfused. They're open at the back that keep the airway open. They're not fused posteriorly, which is the side that's facing the esophagus. Pardon me. This is going to allow the esophagus to expand when you swallow a large bolus of food. The outermost layer is the adventitia. This is a outer connective tissue that holds the trachea in position. The posterior gap that we were talking about, left by the open C-rings, is covered by the trachealis muscle. Now, unlike the pharynx, this is smooth muscle. When it contracts, it narrows the tracheal lumen slightly. This increases velocity of airflow, kind of like during a cough. This is going to help blast foreign material out from your trachea. Now, the carina is, as we mentioned earlier, the point of bifurcation. It's at the ridge at the bottom of the trachea where it splits into the right and left main bronchi. You're gonna notice that the right main bronchus is wider, shorter, and almost like a vertical dead drop. The left is narrower and longer, and it's at an angle degree. Now, why might it be? There's a clinical implication for this. Foreign bodies that are accidentally aspirated tend to go into the right main bronchus because of the steeper angle. This is why right-sided pneumonias and from aspirations are more common. Now, why is the right side more disadvantaged? Let's think about structures that need protection on the left side of your thorax. Can we think of anything important? Yeah, you've got the heart and the pericardial sac. Extreme coughing near the pericardial sac isn't great in terms of friction. The carina also has a reflex function. It's one of the most sensitive areas for triggering a cough reflex. Stimulating the carina during intubation can cause a lot of coughing and, in really bad cases, a bronchospasm. There's two important airway procedures that this anatomy is super relevant for. First up, we've got a tracheotomy. When you see otomy, think cutting into. This is an incision into the trachea made at a level below the cricoid cartilage. Now, a lot of movies and medical dramas love using tracheotomies. They're like, but why would you want to do this? This is typically done to bypass an obstruction in the upper airway, and if you want to do it really fast. So think if someone's airway is closing up from a crushing injury to the larynx or the chest, or if there's an acute severe swelling that closes the airway. When might this be the case? Think anaphylaxis or epiglottitis. It's when you want to bypass all of your conditioning tubes and enter the airway directly. Intubation, on the other hand, is when you pass a tube from either the mouth or the nose, past the larynx, past the vocal folds, through the rima glottis, and into the trachea. Now, this is the preferred method for maintaining an airway in unconscious patients, primarily because it's non-invasive. Knowing the anatomy we've just covered, the thyroid cartilage, the cricoid, the glottis, the vocal folds, These are structures that anchor and guide these procedures. From the carina, we enter the bronchi and the bronchial tree. Now, it's called a bronchial tree because it's kind of like an upside down tree that keeps branching. You've got a single trunk that splits into two, that keeps splitting almost ad nauseum. You've got the first split, the primary bronchi. You've got one primary bronchi for each lung. Your primary bronchi are gonna split again into secondary or lobar bronchi. There's one secondary bronchus for each lobe. If you count 3 lobes on the right, 2 lobes on the left, you've got 5 lobar or secondary bronchi in total. Tertiary bronchi are going to supply individual segments called bronchopulmonary segments. They're super small. Your tertiary bronchi are going to split further and further and further until they're bronchioles. The smaller branches smaller branches are where you're going to see cartilage rings disappear. Terminal bronchioles are going to be your last purely conducting airways. Past this point, we're starting to reach gas exchange zone. As you go deeper into the tree, the epithelium changes. You go from pseudostratified ciliated columnar in the large bronchi to non-ciliated simple columnar in the bronchioles. Why might this be? Because by the time air reaches the terminal bronchioles, it's been filtered enough. You don't need any more cilia to sweep the debris away. But you do, however, need thinner walls to support the transition to gas exchange. Remember, gas doesn't like thick barriers to cross. So we're easing in from columnar into simple squamous epithelia. End is in sight. We're at the alveoli. These tiny sac-like structures are where all of your gas exchange happens. An alveolar duct leads into an alveolar sac, which is a cluster of 2 or more alveoli that shares a common opening. The walls of adjacent alveoli are called the interalveolar septa. This is where you're gonna see branches of your pulmonary arteries carrying deoxygenated blood, turning into capillary beds for oxygenation, leading into the pulmonary vein with freshly oxygenated blood, going all the way back into the heart for future systemic circulation. Keep in mind that the arteries and veins are flipped in terms of what kind of blood they carry just for the pulmonary circuit. But you're smart, you already knew that. Surrounding each alveolus are these pulmonary capillary beds. Now, the respiratory membrane between the alveolar air and the blood is absurdly thin. So we're thinking about half a micron. For context, a human hair is roughly like 70 microns thick. So yeah, incredibly thin. There's 3 layers that a gas molecule must cross. So if you're a gas molecule in the alveoli, to get into the bloodstream, there's 3 layers. The first one is your alveolar epithelia, specifically the wall of the cells. These are called type 1 cells. Don't worry, we're getting into this. We're getting into the different cells soon. But that's the first layer that you're going to want to cross, the epithelial cells of your alveoli. Once you're past the epithelial cell, you see a fused basement membrane. Now, this is super interesting because your epithelial cell of your alveolus and the endothelial cell of your capillary are sharing a basement membrane. Aw, how cute. This is also functionally super important because you're eliminating the need for an entire interstitial layer. And Three layers is a lot easier to cross compared to five. Oxygen diffuses from the alveolus to the blood, uh, because there's a higher concentration of oxygen in the alveolus, and carbon dioxide diffuses in the opposite direction, because venous blood has higher carbon dioxide than the atmosphere. This is just simple diffusion, and this doesn't require any energy in the form of ATP. Now, I mentioned type 1 cells earlier. There's actually two different types of alveolar cells, or pneumocytes. I'm just going to call these alveolar cells for simplicity. Type 1 alveolar cells are the actual simple squamous cells. This is where gas exchange takes place. They're run-of-the-mill, they're thin and flat, and single layered. It's perfect for diffusion. Type 2 alveolar cells are called septal cells. They're scattered amongst the type 1 cells and have microvilli on their free surface. That's how you identify them on a light micrograph. Crucially, these cells have a super unique function. They're gonna secrete alveolar surfactant. This is a phospholipid mixture that reduces the surface tension at the alveoli. Without surfactant, alveoli would just collapse during exhalation. We don't want that. When you think about premature infants, respiratory distress syndrome is essentially this, where infants born before term haven't really developed the ability to produce surfactant, so they're at a higher risk of having their alveoli collapse and require intervention or a ventilator. You've also got a bunch of alveolar dust cells. Now, these are just wandering macrophages that patrol the alveolar surface. Like all good macrophages, they're going to perform phagocytosis. They engulf particulate matter, bacteria, and debris. It's kind of like the lung zone janitorial service. Here's a nice little photomicrograph that shows the architecture within a lung lobule. You can trace the path. There's a terminal bronchial that leads into a respiratory bronchial. This is where limited gas exchange begins because you're transitioning into cuboidal and later squamous epithelia. This leads into alveolar ducts, which leads into alveolar sacs and later individual alveoli. Now, notice how the arterial, venial, and bronchial travel together. They're just wrapped in elastic connective tissue. It's basically organized as a little functional unit. Okay, let's zoom way back out and look at the space that houses all of this, the thorax. The thoracic skeleton forms the walls of your thorax. So we're thinking the sternum, which is the manubrium of the body, the xiphoid, 12 pairs of ribs, and 12 thoracic vertebrae. Since you've got 12 ribs, you've got 11 spaces between them. The spaces between two adjacent ribs, we're calling these intercostal spaces. Remember, cost meaning rib. Each intercostal space contains 3 layers of intercostal muscles, 2 of which you're going to be expected to identify in lab. You've also got a neurovascular bundle. The neurovascular bundle is the intercostal vein, artery, and nerve that runs in that exact pattern in a groove along the inferior border of the rib. So, you're in lab, you're gonna want to look at the inferior margin of a rib, find the little groove, and from superior to inferior, you've got intercostal vein, artery, and nerve. If you think clinically about performing a thoracocentesis, which is when you insert a needle into the pleural space, this is why you want to approach over the top of the rib to ensure that you're not hitting this bundle. The thorax, despite its shape, is oriented like a barrel, like a cylinder. This leaves us two apertures or openings. You've got an upper opening, the superior thoracic aperture that opens towards the neck. Um, and this is where your trachea, the esophagus, and the great vessels pass through. You've also got a lower opening, the inferior thoracic aperture. The inferior thoracic aperture is going to be completely sealed off by a muscle, the respiratory diaphragm. We'll look at this later. The diaphragm separates the thorax from the abdomen. It also makes sense to have a functional partition because your thorax is at negative pressure. It's always lower than external atmospheric pressure because you're gonna want to maintain that negative pressure to ensure inhalation works seamlessly. The thorax also contains three major compartments, two pleural cavities, each containing one lung, and a mediastinum. Okay, hold up. Why is it not called a pericardial cavity? Because there's a bunch of other structures apart from the pericardium. We're thinking the great vessels, aka the inferior superior vena cava, the aorta, and also your trachea and esophagus traveling posteriorly. Let's look at the gross anatomy of the lungs now. Now, both your lungs are gonna share some common features. You've got the base. The base is the part of your lungs that rests on the diaphragm, and the apex of your lungs are these, the part that directly rests above your by your clavicle. Now, you might notice that this is kind of the inverse of what we'd expect to see by the heart, and that's a really important distinction to make. When you consider the heart, this the more superior part where your vessels enter, that would be the base. The pointed tip that's more inferior and distal, that would be the apex. For the lungs, it's more intuitive, but the other way around. You've got base of the lungs by your diaphragm and the apex of your lung superiorly. Let's also look at a few distinguishing features on the lungs. Now, you might notice right off the bat that your left lung has 2 lobes and your right lung has 3 lobes. Let's look at the right lung first. You've got the superior lobe, the middle lobe, and the inferior lobe. Now, the fissures that separate these, you've got an oblique fissure that separates your inferior and middle. You've got a horizontal fissure that separates the superior and middle. On your left side, since you've only got 2 lobes, a superior lobe and an inferior lobe, you've only got a single oblique fissure that separates them. The left lung is smaller because the heart takes up a lot of real estate on that side, which is why you're gonna see a few interesting features, like the cardiac notch over here. You've also got an indentation where the heart sits. This forms the cardiac impression, kind of like a negative space bowl where the heart is. The inferior part of your superior lobe is going to form this tiny little tongue-like projection. We're calling this the lingula. Now, this is the left lung's equivalent of a middle lobe, but since the heart's taking up so much space, we're left with this tongue-like structure. The hilum is where the root of the lung enters. This compact set of tubes, including the primary bronchus, the pulmonary artery, and the pulmonary veins, are kind of like a cord called the root. Now, the space on the lung where they enter is the hilum. You can think about it as kind of like a plug and an outlet on the wall. The plug's going to be the root of the lung, and the outlet on the wall is the hilum. Now, the arrangement of these structures is asymmetric. So knowing the arrangement is going to help you identify which lung you're looking at just from the hilum. There's a handy mnemonic for the pulmonary artery specifically. Think RALS, right anterior, left superior. So your right hilum, the most superior structure is the bronchus, followed by the artery in the middle. On the left, the artery is at the top and the bronchus is at the middle. Your veins always lay low and are the most inferior structures. The left hilum generally sits higher than the right hilum on a chest x-ray, and these are the context clues that a radiologist or clinician are looking for when they're looking at a scan to instantly know what side they're dealing with, instead of trying to find surface features or fissures. Now, we're doing a humongous detour back into embryology. This explains where the pleura comes from. At about 4 weeks, the endoderm gives rise to a little lung bud. This lung bud's going to start growing into the intraembryonic cavity. Now, the cavity, as you might recall, is surrounded by a serous membrane that's adhered to the chest wall. As the lung bud grows outwards, it gets covered in one layer of this serous membrane. This becomes the visceral layer. The other layer stays adhered to the thoracic wall, and it becomes the parietal layer. These two linings are separated by a pleural space with serous fluid filling the space and separating the lining. If you recall the development of the pericardial sac, the whole fist in a balloon model, this developmental origin explains why the pleura has 2 layers, kind of like the heart. It's this whole one membrane that got pushed into situation. The lung essentially pushed into a serous sac. Now, speaking of pleura, the pleura is a double-layered serous membrane. Same concept as the pericardium in the heart. The outer layer is the parietal pleura, and it's attached to the thoracic wall, the diaphragm, and the mediastinum. The visceral pleura, remember viscera meaning organ, is the inner layer. It's directly adhered to the lung surface and extends into the fissures. Between these layers is a pleural cavity. Now, remember that the pleural cavity is a potential space. It's normally just a super thin film of fluid and not an actual open gaping space. If you've got a open gaping space, you've got a problem. Most importantly, there's no connection between the right and the left pleural cavities. This is sort of good news because a pneumothorax on one side doesn't automatically collapse the other one. The serous fluid in the pleural cavity has 2 major functions. Primarily, it reduces the friction between the visceral and the parietal layers. Because think about it, your lungs are constantly expanding and recoiling because of breathing. Without it, each breath would generate a lot of resistance and irritate that inner thoracic lining. It's also going to create surface tension. The thin fluid film that I mentioned earlier creates kind of a cohesive force that keeps the visceral pleura and the parietal pleura stuck together. It's kind of like getting a shower curtain wet and slapping it on a side of the wall to make sure it doesn't slip out. Same idea. This means that when the chest wall expands, the lung is pulled outward with it. Despite having no bony attachment to the chest wall, surface tension makes this possible. Your pleural cavity is also going to maintain negative intrapleural pressure, the thing that I've been harping about all this while. Now, the pressure inside the pleural cavity is always slightly below atmospheric pressure. When you think about The lung, its elastic fibers are always stretched and they always want to recoil. The chest wall wants to spring outwards, and the pleural fluid is balancing this tension between these two opposing forces. So, in a way, it's making sure that your lungs stay inflated even when there's not a lot of air in them. So, at rest. What happens when this fails? Well, we end up with a collapsed lung or a pneumothorax. If air enters the pleural space in any capacity, be it from a chest wall injury, a spontaneous rupture, an infection, a medical procedure gone wrong, it's going to break this surface tension coupling. The result is basically the elastic fibers recoiling and collapsing on the site of the injury. Now, normally your lung is supposed to occupy the entirety of the particular lateral half of your rib cage. So on this individual over here, you can see the lung on the left is full. It's good, it's normal. This is how you expect it to be. The lung on the right, however, highlighted in red, it looks kind of shrunken. That's because it's collapsed. This is a pneumothorax. The lung margin is pulled away from the chest wall. This is leaving us a dark zone of air with no markings. And remember, in x-rays, if there's air, it looks black because air doesn't reflect light back. But again, like I mentioned earlier, since the two pleural cavities are not interconnected, the other lung stays inflated. This is why a lot of pneumothoraces are survivable. A tension pneumothorax, on the other hand, where air keeps entering but can't really escape, that's a lot more dangerous because it causes a progressive buildup of pressure. That's a medical emergency. The mediastinum will then start to shift away from the side that's affected. That's going to compress the other lung and affect the great vessels. That's not good. Now, let's talk about how ventilation actually works mechanically. This little animation over here depicts that the work of breathing is done by skeletal muscles. The lungs themselves are passive. They just follow what the chest wall does. The primary muscle of respiration is the respiratory diaphragm. It's a dome-shaped sheet of skeletal muscle that forms the floor of the thoracic cavity. Now, let's look at the inhalation or inspiration. Do we see the diaphragm contracting and moving inferiorly? That's gonna increase the vertical dimensions of the thoracic cavity. The pleural surface tension is gonna kind of transmit that expansion to the lungs. The lungs are pulled, the volume increases, pressure is gonna drop, and air is gonna fill into the lungs. But when you're at rest, expiration doesn't require any additional muscles. When the diaphragm relaxes, the lung automatically wants to recoil. This causes your chest wall to push air out passively. Again, key word, this is at rest. Now, the main muscle of respiration is your diaphragm, and it's innervated by your phrenic nerve. Your phrenic nerve is gonna arise at spinal level C3, C4, and C5. So we're thinking right above your brachial plexus. Super important to orient yourself in lab. So you're gonna want to look right at the level of the brachial plexus and make sure the nerve crosses the anterior scalene muscle. There's a super cool mnemonic, C3, 4, and 5 keep the diaphragm alive. Woohoo! Since the phrenic nerves are the only nerves that innervate your diaphragm. So, your phrenic nerve travels from the cervical region, C3, 4, and 5, and enters the thorax through the superior thoracic aperture. It's going to descend along the lateral aspects of the pericardium and reach the diaphragm. A clinical implication, a cervical spine injury at or above C3, 4, and 5 can paralyze the diaphragm. This would then require ventilator support. This is why high cervical fractures, this is another reason why high cervical fractures are so dangerous. At rest, only the diaphragm, with some assistance from the external intercostals, handles breathing. But under force conditions, think exercise, distress, or exertion, we're gonna recruit some help from accessory muscles. When you're thinking about forced inhalation, you're thinking about muscles that elevate the rib cage and move it up and out, so muscles superior to the thorax. This helps increase the thoracic volume. So think pec minor, serratus posterior superior that elevates the upper lips, and your sternocleidomastoid that elevates both the sternum and the clavicle. It's going to expand the superior thoracic aperture that way. Forced exhalation, on the other hand, recruits muscles that are inferior to the thorax. You're going to want to compress the contents of the abdomen and push the diaphragm up, or you're going to want to actively depress the ribcage and pull it inwards. The muscles that do this are all of your abdominal muscles, so think rectus abdominis, obliques, and transversus. These are compressing the abdomen and putting pressure on the diaphragm to help it move up. You've got the serratus posterior inferior, which is gonna pull down and depress your lower ribs. A bunch of your internal intercostals also pull your ribs down and inwards and compress your thoracic volume. So the next time you're out of breath after sprinting somewhere, remember your accessory muscles are trying really hard to help you. There's a few details that'll help you distinguish the internal and the external intercostal muscles, especially in lab. If you're trying to identify the external intercostals, you're gonna want to try looking for fibers that go down and in. You're thinking inferior and medial, down and in. It's kind of like putting your hands into your pockets. If you see muscle fibers that follow that direction, those are external intercostals. For your internal intercostals, you're gonna think up and in. So it's kind of like crossing your hands over your arms. If there's muscle fibers that go up and in, they're probably internal intercostals. And that's the respiratory system. From nose hairs to alveoli, you now know how air gets in, how it's conditioned, how sound is produced, how gas exchange happens, how ventilation is mechanically driven, and what keeps your lungs from collapsing every time you exhale. Oof, I'm so out of breath already. And I'm so proud of you for making it this far. Before your next lecture or lab session, make sure you can name the epithelial linings at each level of the respiratory tract, trace the path of air between two spaces, identify cartilages of the larynx with their functions, as well as the muscles of vocation, and know the innervation of the diaphragm. You've so got this. Good luck, and I'll see you super soon. Bye now.